endometriosis is a disease in which tissue, similar to the lining of the uterus, grows outside the uterus. As you can see here in the diagram, it can cause severe pain in the pelvis, and it does make it harder to get pregnant for the patients that have it. It causes subfertility. The issue with endometriosis is there is a delay in seeking help because we tend to normalize period pain. And this is severe pain. It's considered normal, and severe pain is often overlooked. So there is an average of 7.5 years, that is about 4 to 10 years between first presentation and diagnosis. So an average of about 7.5 years to make an accurate diagnosis. It is common, about 10 to 20% of the population suffer from it, and about 26 million in India. So as you can see, endometriosis in this diagram is when it is displaced anywhere outside of the uterus. It could be anywhere in the pelvis. Of 44% of the time, it's in endometrioma. As you can see, there's a small diagram there. It forms the cyst in the ovary. It can go anywhere. Even there have been case studies, rare ones, to the lungs, sometimes scar tissue. Okay, so let's see what causes endometriosis. Unfortunately, we do not know exactly what causes it, but there are a few theories that we have. One is it could go through the blood or lymph system, that it is transported through other areas of the body through our blood and lymphatic system, kind of like a passageway. Okay. Or it could directly be shifted there, that is direct transplantation. It could attach to, like the abdomen or any C-section scar, things like that. Genetics, it affects some families more often than others, so there could be a genetic link to the condition. Reverse menstruation, endometrial tissue goes into the fallopian tubes and the abdomen instead of exiting the body during a woman's period. Other cells in the body may become endometrial cells in transformation and start growing outside the endometrium. Okay. Now, this is just a diagram of ways that endometriosis can happen. Okay, just retrograde menstruation, direct implantation, often the rectum. Okay, let's move on to risk factors, which I'm sure everybody wants to hear about. One is low birth weight, being underweight, the low BMI, shorter menstrual cycles, genetic, some 7 to 10 times more likely to be affected if there's a first degree relative that is. Now, the things that decrease the risk are greater parity, regular physical activity, lactation, fish and omega fatty acids. These are lesser, there's less proof around this, but greater parity definitely is a factor. That is, those that have more children are less likely to be affected by endometriosis. It could be due to the hormonal exposure. Okay, now, what can endometriosis cause? An emotionally distressed individual, because they're suffering from so much pain, and it's a constant chronic pelvic pain for nearly 6 months. More sick days, severe pain, tiredness, physical pain, and psychological and social impact. It is often mistaken for irritable bowel syndrome, interstitial cystitis, adenomyosis, adhesions, sometimes pelvic inflammatory disease. An accurate diagnosis can be very challenging. Symptoms. Some people with endometriosis actually do not present with any symptoms. For those who do, a common symptom is pain in the lower part of the abdomen, that is the belly, okay? And before, during, and after the period, a lot of the time before. Then during or after sex, this is called dyspareunia, okay? We find that a lot of the time, I will go into how it presents as dyspareunia. It's usually deep dyspareunia, that is during penetration, okay? While urinating or defecating, and chronic pelvic pain, which is intermittent or constant lower abdominal pain, which lasts for 6 months or so, okay? It needs to have a minimum diagnosis of 6 months to, like a minimum symptom of 6 months to be made as a diagnosis, okay? Some people also present as heavy bleeding during periods or in between periods, trouble getting pregnant, as we've talked about, bloating or nausea, fatigue, depression or anxiety because of, like, a lot of the time because of this horrible pain that they're going through. Okay, just going back to my point, which is why there are more sick days, severe pain, tiredness, psychological impact. Okay. Then let's go to how exactly we as doctors will diagnose you as endometriosis, and we'll walk you through the steps. First and foremost, we take a really good history, okay, wherein all of these symptoms that I have enumerated here, that is during the period, while urinating, defecating, all of that, we take a very thorough history, following which we do a pelvic examination, which is a vaginal or internal examination. Okay. Now, there isn't that much that we can know on vaginal examination, but these are some of the things that can happen. Okay. Now, an endometriosis, as I said earlier, goes into the ovaries. It's called endometrioma. In that case, we can easily palpate the ovary. Okay. And there's also a deep, like I explained dyspareunia, there's a deep pain on examination as well. Okay. Sometimes the uterus is fixed in one place because of the deposits on the ligaments of the uterus. Okay. And often, very rarely, there may be some nodules that's there in the that can be felt towards the rectum. Okay. So this is as much as physical examination. Moving on to ultrasound diagnosis, unfortunately, there isn't that much that an ultrasound can tell us unless it is a fluid-filled cyst. Little endometriotic nodules aren't often caught on ultrasound. There is no way of knowing this. More severe disease may be seen on MRI because there's hyper intense nodules that can be picked up. But ultrasound isn't very useful for us. Imaging doesn't go a long way. The definitive diagnosis is laparoscopy, which is a small camera which looks inside the body to identify the endometrial deposits. Okay. Effects of endometriosis. Up to 50% of women with endometriosis have trouble conceiving. Most of them, as I said, express anxiety and depression during pain. And variable signs and symptoms contribute to significant diagnostic delay because, it can, as we've enumerated earlier, it can present as pelvic inflammatory disease. It could be confused to be a UTI. We could think it's irritable bowel syndrome. The list goes on and on. Then, looking to the next step is, how do we treat endometriosis? Well, there are painkillers, like non-steroidal anti-inflammatory drugs, which are more symptomatic relief. There's hormone therapy, birth control, oral contraceptive pills, gonadotropin-releasing hormones, and danazol. Now, each of these have a lot of pros and cons. Like, for example, birth control is really cheap, easily available. However, how it works is, what birth control does is it kind of prevents ovulation from taking place. We give them as a pack, like a continuous pack. So also it gives the endometrium a break. There's no change happening in that time. There's no bleeding happening that time. So it's good symptomatic relief. Gonadotropin releasing hormones, GnRH, they tend to stop they stop the woman from menstruating, and then we do a little add back therapy where we give them back some hormone, which is to help prevent the menopausal symptoms. Then there's danazol, but it isn't often used because of it has androgenic effects. And then there's progestin, which people may avoid because it sometimes gives the PMS symptom, but it prevents ovulation from taking place. And then there's aromatase inhibitor. As you know, in the endometrium, aromatase acts in the endometrium. So by inhibiting it, we prevent the endometrium from proliferating. Okay. Now, surgery, while it is definitive, 67% of patients have reported that surgery is the gold standard because it's diagnostic, as well as we can treat. It's like see and treat method. When we're doing the surgery, we can cauterize and ablate the little endometriotic nodules so they stop bleeding at the time, which is what happens, right, in endometriosis. There's nowhere for the blood to go, so it causes a little buildup, scarring, inflammation, which leads to pain because of congestion and pelvic inflammation. Okay, so while 67% of them had improved symptoms, 33% had to have repeat surgery within 5 years. Alternative methods that we've heard about are immunomodulators and vitamin D3. And pelvic floor physiotherapy has come a long way, especially in the symptomatic management of this disease. Now, what to do if you're having endometriosis? What should the first step be? Well, to start off, we'll first reach out to your gynecologist and we'll teach you how to manage the painful period. We can, as I said, give you non-steroidal anti-inflammatory drugs, and we can give you like ibuprofen that helps symptomatic relief. However, these only prevent the symptoms, not the cause. And then after that, we can refer you to a physiotherapist who can help deal with the symptoms of painful intercourse, pelvic and abdominal pain, dysmenorrhea, that is a painful period, constipation, and recovery from surgery for endometriosis. So we like to do a multidisciplinary approach and go hand in hand. We understand the pros and cons of each treatment, and we can help you do that. We help guide you towards an apt treatment based on whether fertility is desired or not. Because going back here to this page, birth control, GnRH, danazol, progestin, aromatase inhibitors, all the hormone therapy, the birth control, the GnRH, and the danazol, they all stop the period from happening, right? So that is what we require ovulation to conceive. So all of those aren't really plausible, like feasible treatments for people who are trying to conceive. However, that is why endometriosis requires a tailor-made approach for treatment.